We're about to hear from the Secretary of State for Health. Very pleased that he's here, and he's going to be taking your questions after he delivers his keynote address to Expo 15. So please welcome the Right Honourable Jeremy Hunt MP.
Thanks, Michelle. Well, good afternoon, ladies and gentlemen. Thank you very much for coming. It's a great privilege to be speaking to you from a pavilion called the NHS Future. Just 4 months ago, I thought I might be part of the NHS Past, and I was very privileged to be able to come back to this job. I remember Steve Jobs, when he was alive, had a saying. He said, "Let's go and invent the future and not worry about what happened yesterday." Given the history of government involvement in NHS IT contracts, I'm not sure if that's wise advice or unwise advice. But I wanted to come to Expo because I believe that innovation is going to be absolutely central to the future of the NHS. And getting it right is what this incredible exhibition is all about. It's gone from strength to strength. It's busiest ever this year, and I want to share with you some of my thinking about how we need to embrace innovation going forward in the future of the NHS. And the first point to make is that innovation in healthcare in Britain is nothing new. We were the country that discovered the link between dirty water and cholera, which effectively founded what's now known as public health. We discovered penicillin, antibiotics, anesthetics, MRI scanners, CT scanners, the research that allows us to do IVF, hip replacements, and many, many other things. But here's the curious fact. When you look at the way the internet has transformed so many aspects of our lives, it seems very often that healthcare is at the back of the queue. And not just in this country, but all over the world. Have a look at this slide. So 84% of the people in Britain use the internet, 59% of people use a smartphone, but only 2% of people interact digitally with the NHS. I feel I'm giving Michelle a question to throw at me at the Next Today programme interview, but I just came back from my holidays and I used Airbnb to book part of those holidays, and it was a good experience. And when we think about how we use the internet for shopping, for banking, for so many aspects of our lives, we've still barely scratched the surface when it comes to healthcare, which is curious because healthcare matters more to us than any of those things. So, here is the question. Can Britain step up to the plate and be a global leader in the use of innovation and technology in healthcare in the way we have done so often in the past? And I believe we can, but there are some very important things we need to do to make that happen. And there are really 3 stages to that process, and I want to take you through what I think those 3 stages are. The first is to use the power of data to create a culture of intelligent transparency throughout the NHS. Now, transparency is something that we have been talking about for a long time. The NHS is already the most transparent and open healthcare system anywhere in the world. But this actually is a process that started many decades ago. One of the key moments that it started was in the early 1990s, when a cardiac surgeon called Bruce Keogh, you may have heard that name because he's now medical director of NHS England, but Bruce, as a cardiac surgeon, decided to try to persuade his cardiac surgeon colleagues that they should collect information about their mortality rates and try and learn from them and compare them and see if they could use that information to improve mortality rates. It took Bruce 13 years, working with a number of other people like Ben Bridgewater and others, to persuade the Society of Cardiothoracic Surgeons that they should do this. But the result was a dramatic reduction in heart surgery mortality rates, a reduction of around a third. And that's now gone further. Last year we became the first country in the world to publish mortality rates for 12 surgical specialties, and we're looking to do it for some of the medical specialties as well. Now that same Bruce Keogh took another giant step towards transparency on the 13th of July 2013, when in response to the Francis report into the tragedy of what happened at Mid-Staffs, Bruce did a snap inspection of the 14 hospitals with the highest mortality rates. And he recommended to me that we should put 11 of those hospitals into special measures. Now, that had never happened before in the history of the NHS. Nearly 10% of all NHS acute trusts put into special measures. And there was a huge amount of nervousness when we started that process. People worried that publicly announcing the names of hospitals where we didn't think the care was as safe as it should be would mean that doctors and nurses didn't want to work at those trusts, that patients would desert them, and that they would end up in a vicious cycle of decline. Actually, the opposite happened. Those hospitals had a dramatic turnaround in the quality of their care. 8 have already come out of special measures, around 1,000 more nurses, over 100 more doctors across those trusts, and according to one study, 450 lives being saved every year as a result of improvements in care. And that shows the power of intelligent transparency. And it also shows that it is not about naming and shaming. It is about harnessing that innate desire at the heart of every doctor and nurse to do a better job for their patients. But you can only do that if you share information about the quality of care that's being offered by comparison to your peers. And hospitals that have developed that culture internally, such as Salford Royal, I'm pleased that David Dalton is here, Frimley Park in Camberley, demonstrate time after time that having an open and transparent culture is the way that you improve safety for patients. Let's have a look at another industry that has done this extremely successfully. This is the airline industry. And graph 1 is a rather grim graph because it's actually the number of plane crashes every year across the world from 1980 to 2009. And as you can see, it's fallen pretty consistently across that 30-year period. Graph 2 is the amount of air travel that has happened actually over a slightly longer period, but it's actually gone up by about 9-fold. So what you can see is that the airline industry has managed to dramatically reduce the likelihood of air passengers being involved in air crashes over that period. Now, how have they done that? And they've done it because in the 1970s, they realized that unless they managed to reduce the amount of air passenger fatalities, they wouldn't have a business. The public would lose confidence in the airline industry. And they needed to change the culture of flying to achieve this very significant reduction. And how did they do that? Well, they thought very hard about the culture inside the cockpit of an aeroplane. I want you to imagine a horrific thought for a moment. Imagine Michelle and I were flying you as pilot and co-pilot across the Atlantic in a 747. In the 1960s and 70s, if I made a mistake, and assuming we survived that mistake, the culture was very much that I would look at Michelle and she would look at me and we would say, well, that never happened, did it? And the last thing we would want is for British Airways or the airline to find out about that mistake because we worry that we might lose our job. And so there was a culture of cover-up when instead of what you needed, which is a culture of learning. So the airline industry set about changing that culture so that the most important thing when you have a mistake as a pilot, when you have a near miss, is that it gets reported. And in fact, as a pilot, there are around 5 different ways that you can report mistakes. You can report them anonymously to the airlines union, you can report them to the CAA, you can report them to your airline. You can report them all these different ways, and professionally you are protected, provided you haven't broken the law, as long as you report that error. The most dangerous thing, to give that example of me and Michelle, the most dangerous thing for either of us, if we make a mistake now, is not to report it. And what happens when you report those mistakes is that immediately there's an investigation. If it's a serious mistake, an independent investigation, and the industry makes sure that the appropriate lessons are learned. And that's why they have that spectacular improvement in safety. Now, medicine, for all sorts of reasons, but medicine has taken much longer to develop that approach to safety. And that's what Bruce, who I hadn't realized was here, that's what Bruce was trying to pioneer with his publication of cardiothoracic heart surgery mortality rates. And that is the culture of transparency, intelligent transparency, that we are looking to see in the NHS. And we're taking another giant step towards that in March, when we will become the first country in the world to publish the performance, the quality performance for different patient groups across every CCG in the country. And this is some work that's being done at the moment by the King's Fund to help us understand how they would do this. So the CCG, the organisation that's responsible for commissioning your and my healthcare in every local area, will be assessed, and we will publish how good their care is for older people, how good their care is for people with long-term conditions, how good it is for adults, how good for children, and how good it is for people with mental health conditions. And we'll publish that on an annual basis. And the purpose of that is for us to understand where, for example, the best mental health care in the country is, and where we've got problems, and to make sure that we then do the necessary learning to reduce the variations in the quality of care that we all know are far too high across the NHS. So intelligent transparency is the first step, and that then leads to a true learning organisation. The NHS is the world's 5th largest organisation, and I have said I would like the NHS to become the world's largest learning organisation. I think we can do that, and we've gone further and faster in transparency, but it has to be transparency with consequences. I don't know where I should stand. It has to be transparency with consequences, and becoming a learning organisation is part of that. Let me just give you a couple of examples as to how this will have a direct impact on the quality of care that we offer. 137 people die or are seriously harmed every year because of medication errors. Many of those medication errors could be avoided if every doctor or nurse had access to a proper electronic health record that could tell people someone's allergies, their medical history, their appointments, and so on. And that is why making sure that we have proper information available through electronic health records is absolutely critical going forward. That's an example of where intelligent use of data is really important. Another is the yellow card scheme that was developed in the wake of the thalidomide scandal that's had enormous dividends in helping us to understand what new developments can help save lives in relation to stillbirths and premature births. Then again, if we look at maternity, the work done by Tim Draycott at Southmead in Bristol, turning that hospital into one of the safest maternity units in the world, that is all about learning and transparency and looking at data, and that's going to be a very big focus going forward. So stage 1, intelligent transparency. Stage 2, making the NHS into the world's largest learning organisation. But then there's the final stage, which is taking all that information and putting it into the hands of patients. And that's the most exciting part of all. And we've again made very good progress in the last few years. A year ago, only 3% of GP surgeries offered patients access to a summary of their medical record. That's now gone up to 97%. But I want to go further, much, much further. And so today I can announce 3 very important ambitions that Tim Kelsey at NHS England has committed to. I don't know where Tim is today, but he will be probably slightly quaking that I'm being public with this now, but I think he is as excited as I am by this prospect. So the first is that at the moment, we can only access online a summary of our medical record. By 2018, we will make sure that every NHS patient can access their whole medical record, and we are going to try and make sure that that is a read and write access as well, so they can actually contribute to their own medical record as well. By 2018, we'll make sure that with a patient's consent, that medical record can be accessed not just in your local hospital, but anywhere in the country. And then it's really important that this isn't just about the ability to access your record or to book appointments online or to order prescriptions online. Take-up really matters. And so NHS England has agreed to try to deliver the ambition that within the next 3 years, a quarter of all smartphone users, as we saw from the earlier slide, that's about 2/3 of the population, a quarter of all smartphone users will be electronically accessing their NHS services, accessing their record, booking their appointments online, will be using a great suite of health apps that now exist, many of them that you can find out about at Expo, to access our own medical information. Now, why does this matter? Of course, there's the convenience factor, there's the efficiency factor, all the things that we're familiar with. But again, it goes back to this power relationship between doctors and patients, because the evidence from all over the world is that when patients start accessing their medical record, they then start to think about their healthcare in a different way. Doctors say that if someone refuses to change their diet, if they refuse to take exercise, in the end there's very little that a doctor can do to reduce the likelihood of disease. But when you have shared access to a medical record, it becomes a shared endeavor. You share the responsibility, and the world's most powerful patients become the world's healthiest patients as well. So that is the exciting journey that we want to go on in the NHS. But the truth is that we will throw this all away if we lose the public's trust in our ability to look after their personal data securely. And I just want to finish by reflecting on the importance of that. Nothing matters more to us than our own health. But if we recognize that fact, we must also understand that for NHS patients, nothing matters more to them than confidence that the NHS will look after their own personal medical data with the highest standards of security. And the truth is that we in the NHS have not won the public's trust in our ability to do this, as today's completely unacceptable data breach and the Dean Street surgery demonstrates. And if we are going to win that trust, we need to strengthen the independent oversight of data security within the NHS to a level that we don't have at the moment. I set up as Health Secretary a new role, a National Data Guardian, Dame Fiona Caldecott, who's done a fantastic job taking on that role. But I want to go a step further, and so today I'm announcing that we are consulting on putting that role, the National Data Guardian role, onto a statutory footing. I want Dame Fiona to be as powerful a voice for patients when it comes to the protection of their own personal medical data as Professor Sir Mike Richards has become as Chief Inspector of Hospitals, or Professor Steve Field has become as Chief Inspector of General Practice. And putting her role on a statutory footing will be an important step towards that. I'm also going to do something else today, which is to ask the CQC to do a thorough and independent investigation of the effectiveness of data security when it comes to protecting our personal medical data throughout the NHS. And they're going to use their inspection process to actually look on the ground at how good we are at looking after people's personal medical data. Dame Fiona will contribute to that review a new set of protocols against which we will hold every NHS organisation to account for the protection of personal data. She will also advise us on the precise wording that's needed for the consents and opt-outs for the care.data programme, which is so vital to the future of the NHS. And that report will be completed by the end of January, and then from April next year, we will implement the recommendations in that report into the inspections that are done by the CQC and into the commissioning process that's done by NHS England. So I hope that will be the first step in regaining the public's confidence and trust that we in the NHS are doing everything in our power to make sure that the way we look after personal data is as robust as they have a right to expect. Let me just finish by going back to the vision for innovation: intelligent transparency, a learning organisation, and powerful patients. And I just want to finish by saying this. Putting power into the hands of patients is not a new thing for the NHS. It's actually why the NHS was set up in 1948. Bevan set up the NHS because he wanted to eliminate the powerlessness of patients who couldn't access healthcare because they couldn't afford it. Now, putting power into the hands of patients today is very different to what it was 70 years ago. It allows us, through the power of technology, to share information, to share learning, and ultimately to share responsibility for our own healthcare in a way that Bevan could never have dreamed of. But it's a very exciting vision. I want the NHS to get there first. So as Steve Jobs said, let's go and invent the future. Thank you very much.
Just a couple of questions to start off with. You've outlined something very ambitious. By 2018, patients will be able to access their entire medical records online. How much will that cost?
Well, I can see the a Future Today programme interview being lined up here in 2018, if I'm lucky enough still to be Health Secretary by then. But the answer is that cost is not really the issue here, because it's about connecting up GP medical records that we already have with hospitals and with the social care system, which actually will take until 2020. And it's about doing that in a way that is secure for patients. We are already in the process of doing that. A third of A&E departments can now access GP medical records. A third of ambulance services can now do that. Making it possible for patients to access their own medical records is just something we need to do, because in the end, patients own their own medical data. So it's a question of doing it in a way that is secure, and also a way that is meaningful to patients, because a lot of the information in medical records, if you and I looked at, would be gobbledygook, and so we need to find a way of doing it in a way that's meaningful for patients.
But I mean, it's a big ambition to have, and I'm assuming you have costed it, and you think it's affordable.
It's completely affordable within the budgets that we have for the NHS.
Even, obviously people have long memories about IT projects in the past. I mean, which spiraled out of control. You have confidence that this is deliverable in the time frame you've set out?
I do. And, to give credit to NHS England, they have delivered every single major IT ambition that I've asked them to deliver since I become Health Secretary. There was a very big ambition to make sure that every patient could access a summary of their own medical record by the time of the general election, and they deliver that for 97% of patients. So I'm confident that they can do this.
It's an interesting idea to be able to contribute to your own medical records. In what way do you think a patient would contribute? What are you imagining they would add to their record?
Let me give you two examples as to how I think patients can do this. Where they have allowed people to access their own medical record in the US, the first thing that they've noticed is that patients spot mistakes. And they say, actually, you didn't give me this medicine, you gave me that medicine. I didn't meet you on that date, I met you on this date. And so medical records become a lot more accurate. And people have been quite surprised at the improvements in accuracy of medical records when patients are able to access and contribute to their own medical record. But in a way, that's just the start. I mean, many people wear these Fitbit devices which sort of measure how many steps you've taken every day. If you were willing, and this is obviously something that has to happen with consent, but if you were willing to connect that information to your medical record, it would be incredibly helpful for a doctor to know how much exercise you've been taking every day. And that's the kind of way in which a partnership between doctors and patients can make a medical record far more meaningful going forward if we're trying to prevent diabetes, for example.
And it was interesting what you were saying about it, that your hope is that it makes the patient think differently about their health, which is probably the biggest value that can come from it if you think that in this era of scarce resources, prevention is going to be all important.
Yes. Hippocrates said all those years ago that the best doctor is the patient. And we're in an era of long-term conditions, chronic conditions, mostly not curable, but conditions that have to be managed, which means if you're a type 2 diabetic, that your involvement and the sense of responsibility you have for your own healthcare is critically important in a way that's different to someone who needs a new knee or a new hip, where effectively it's really the job of the doctor to do the job effectively and safely. And so that's why this is such an important change.
Okay, could you raise your hand if you've got a question for the Secretary of State, and we'll try and group them together, and then, so could we get one to the gentleman here, and then we'll take two questions over there right in the middle of the row, and then we'll come back to you. Go ahead, sir.
Thank you, Michelle. Dr. Kailash, Deputy Chair, BMA Council. It's not a question, it's more of a plea and request to you, Jeremy. I don't know whether you remember or not, when you were appointed Health Secretary, I met you then. And I was very impressed with your vision, the way you're looking at what you want to give in your tenure as a Health Secretary. And today is again a very visionary one, and I think nobody can disagree with that. And one thing you told me that time was that to deliver your vision into real executing it, you need cooperation of BMA, and you will work with BMA. But history now tells us something different. Particularly on 7/7, you have said that BMA is a roadblock, whereas we are saying we are ready and willing to work with you as long as you provide us the necessary resources and infrastructure. Now, isn't it the time, if you want to translate your vision into reality, that you work with the NHS family rather than having a divisive policy?
Okay, thank you very much. Can we take the two questions over there in the middle?
Oh, sorry.
Yes.
Hi, Mr. Hunt. My name's Osama Said. I'm a final year medical student at Imperial College. So a couple of times during your speech, you mentioned the idea of intelligent transparency. So I was wondering, in this context of phraseology, what would constitute unintelligent transparency? So what is going too far in that frame of things?
Okay, thank you. And is there was someone very near you with their hand up? Yeah.
Thank you, Dr. Sue Crossman, Chief Officer of a CCG in West Norfolk. My question is around your direction to the CQC to inspect trusts and see whether they're complying with patient confidentiality. My understanding of Dame Fiona's Caldecott guidance is that she revisited it because of the unintended consequence it was having on the ground. And that a lot of the information that we get from patients and clinicians is that there's a huge reluctance and a great inhibition to do what patients actually really want them to do, which is share their information appropriately because of the fear. And I'd just be interested in your comments around inspection versus good sharing of information.
Thank you. where would you like to start of those,
Shall I do it
three?
in reverse
Go
order? I mean, Sue, I think your point about the nervousness of clinicians about sharing data is right. And certainly we need to make sure people understand exactly what their legal responsibilities are. But Dame Fiona has rightly said that we also have a duty to share data when it's in the interests of good patient care. And indeed, the vast majority of NHS patients would be astonished to know that their local hospital can't access their full GP record, which is the case now, which we need to put right. But that needs to be done with the knowledge and consent of patients. And we need to carry the public with us. So that's one of the reasons why Dame Fiona will be looking at what the security protocols need to be for the protection of personal data. And the NHS, like all large organizations, is vulnerable to cyber attacks, for example, and the public have a right to know that we have the latest antivirus software, that we have the latest physical security surrounding the servers that are looking after their personal data. And that's why she's going to do this important piece of work going forward. Osama's question about what is unintelligent transparency? Well, this is a really important point. So, unintelligent transparency would be, for example, to look at the hospitals that publish the greatest number of never events, wrong site surgery, for example, or leaving foreign objects in people's bodies, and to say, because you publish the greatest number of never events, your care must be the least safe. When in fact it might be that they just have the best reporting cultures in those hospitals that are best at encouraging the doctors and nurses to report safety incidents that aren't reported in other hospitals. And that's why we need to be very careful about the way we present this data so that we get the right conclusions and we don't have the unintended consequences that happen when it's presented in an unintelligent way. Kailash's point about working with the BMA over 7-day working, that is exactly what I want to do. We have been talking to the BMA for 2.5 years now about 7-day working. We are putting more resources into the NHS in order to deliver 7-day working, but hospitals tell us that the biggest single obstacle to being able to get the consultant cover they need at the weekend is the opt-out. We're only asking doctors to work up to 1 weekend in 4, the same as nurses, paramedics, other people who work in hospitals. The vast majority of doctors do already do some weekend work, but if we're going to make sure that we reduce the avoidable deaths that we currently have at weekends, that is one of the significant problems we have, and we would love to talk with you, but we have talked for a long time about it, and that's why I thought it was necessary to bring the issue to a head if we're going to deliver the safe patient care that we all want.
You still think that was the right thing to do? Were you surprised by how, the kind of fury of the backlash?
Well, I think that perhaps doctors misinterpreted what I said as being a suggestion that they don't work weekends. That's never been what I've been saying. But the reality is that the BMA have been opposed to changing this contract, and they were going to try and fight back in whichever way they could. But I have made it very clear that we have to do the right thing for patients, and the weekend mortality rates are unacceptably high. And I just think this is one of those things that we have to do.
Okay. Can we get the microphone one microphone over there, and anyone at this side of the room? Okay, I think, right. And can we get the other microphone to the back of the room, please, to the lady right at the back of the room? Yes.
Thank you, Michelle. Dr. Bettina Experton, CEO of Umetrics, San Diego-based company. And I flew all the way from San Diego to come here, and we even opened a subsidiary in the UK because you have the means to deliver on your promises. I believe so, Mr. Hunt. When you say that by 2018, 2/3 of our British citizens will be able to access their medical record on their mobile device, yes, you can, because we do have the technology. We won the Blue Button competition in the US, invited at the White House for that innovation, but you in the UK, in the NHS, have the means to deliver. You have the ability, you have the infrastructure. Tim Kelsey and his team successfully deliver on their promises before the election, not only to give citizen access to their summary care record, but for the whole EMR industry to give this application program interface API, so my application like iBlue button and others can link that data. So that was to say that we can contribute to your promises.
Okay, thank you. And did you have a question? The lady, oh, that's the same. Okay, so lady at the back there.
Yes. Yes, I wanted to ask you, in view of what you said during your speech about next March having an overview of the way CCGs help different areas of the population, can I ask you specifically, please, to hive off the severely demented and their carers and look carefully at what is happening there? Because from experience, there are, certainly in our area, no neuropsychologists who can do an overarching assessment of the mental and physical health needs of the severely demented, which then stops them getting the help they need.
Thank you. And gentleman over there. Yes. If you could stand up. That'd be great.
Sorry,
Thank you.
I hadn't realised. Tony Johnson, Health Watch Stock Board. I just wonder if you could say something about equity of esteem for mental health and the extent to which more of the NHS funding should be more appropriately given to achieve this objective.
Thank you. Jeremy.
Fine, let me take those again in reverse order. So Terry's question, mental health is very important. We are committed to new access targets for early access to psychosis. We have targets for waiting time targets for IAPT as well. And we changed the law to introduce parity of esteem for mental health, but we need to make a reality of that, and we haven't done that yet. I think a very big step towards that will be, it's not up there at the moment, but will be the publication of the quality of mental health care by CCG across the country, so that we're able for the first time to compare the parts of the country which have good quality mental health care and which parts don't, and then do something about the areas which are deficient. The question from the lady back about dementia, it's very important. I mean, we had a big push on dementia in the last Parliament, and I think we now have the highest, or one of the highest dementia diagnosis rates in the world. It's up at 2/3. But the quality of delivery for people who get a dementia diagnosis is still very patchy. So one of the key bits of work that we're doing at the moment is, and it will be published transparently so that everyone can see, is to look at the quality of access to dementia care in different parts of the country and how we can improve that. So that's a very important part of the intelligent transparency agenda. And then Dr. Batia, thank you for coming all the way from San Diego. And I think that, I'm delighted that you have technology that can help us in this journey. We signed a memorandum of understanding with my US counterpart, the Secretary Sebelius as it was then in the US, so that we have a common approval system for apps that people can use to access their own medical records, so that an app that's approved for use in the US medical system can be used here, and an app that's approved here can be used in the US. And I think that will dramatically widen the choice for NHS patients. What I hope we will get is a lot of condition-specific apps. So developers will do, maybe Diabetes UK will do a diabetes app, or the Alzheimer's Society will do a dementia app that sufferers with particular conditions can use.
I think you might need to loop it back over your ear. Sorry.
Thank you.
Yeah.
Right.
Yeah, that's better. Okay, thank you. Did you have a question? Did you have a question? Hang on. Microphone. Yeah. Sorry. Could we get one to this lady there? And could you get one to... actually, just hang on one second. We literally don't have very much time. One to the gentleman at the back there, and then we'll come to you in the middle of that section there. Go ahead.
Yeah, quickly. Can I just say that for everyone on the floor, those of us living well with dementia, we're not demented. Okay.
Okay. You don't like that term?
No, I
Noted.
don't think it's helpful at all.
Thank you.
Thank you.
Thank you very much for making that point. Yes, sorry, someone in the middle. Yeah.
Mr. Hunt,
Could you stand up, please? Sorry.
Mr. Hunt, you talk a lot about looking to the future, which is great, but if we're just spending our time looking up at the clouds and we walk off a cliff, then it's going to end tragically. Do you think most patients would much rather not have to wait 4 weeks for a GP appointment than they would have access to their health records? Is there a risk that we'll end up becoming distracted from what's happening already?
Okay, thank you. And I think just one last question there. Thank you.
Hi, Campbell Murdoch, GP in Somerset. Thinking of innovation and the implementation of innovation, one of the key things we need to do is reduce inertia. Dealing with humans every day, 50 humans every day, I see one of the big drivers for inertia is uncertainty and the human quality of fear of uncertainty. One of the things that drives that is a lack of relatedness between parties, and this fits then with collaboration of providers of care and collaboration with the patient. What methods would you suggest that may improve relatedness between all parties involved in care and therefore reduce inertia?
Thank you.
Okay. Well, two very important questions to end up with, and both coming in away from slightly opposing directions. But let me take the point about inertia first. I think the biggest way to create inertia is for people to think that the change that we want to see in the NHS is being driven from the top, and that this is all about doing what the Secretary of State for Health wants. And I think this was really what went wrong with Connecting for Health, which was actually a fantastic vision. But in the end, it became like the NHS's equivalent of building an aircraft carrier. It became massively overspecified, massively complex, and implementation didn't have strong local ownership. And I think the way that we'll remove that inertia is for people to feel that the broad objectives are being set by NHS England, by the centre, improving the quality of care, improving the safety of care, improving the care for people living with dementia, and so on. But the solutions are local. And that's why, incidentally, just to relate to Michelle's point, I have more confidence about the costs relating to this, because we aren't trying to design the entire programme from the centre. We are very much leaving it to local CCGs. There's a fantastic display of the work being done by the 29 Vanguard projects as to how these new models of care can work in practice. So I think local ownership is really the key. But I want to just finish with the gentleman's point, about the very real pressures on the NHS frontline today, because you're absolutely right. The NHS has never been busier. There's huge pressure in our A&E departments, huge pressure in GP surgeries. People do have to wait too long to see a GP. And we are working very hard to address those issues. There's a whole new approach to urgent and emergency care that Professor Bruce Keogh is developing, with plans to recruit around 5,000 more GPs to ease pressures there. But I don't think that there is a choice between embracing the future or dealing with the pressures of the present. If you just take the single example that you gave me about having to wait too long for a GP appointment, many GPs are using technology to make sure that their patients don't have to wait too long for appointment. For example, by having an online diagnostic tool that can solve someone's problem without them actually needing to see a GP, or by having telephone and Skype appointments with a GP that save the need to visit a GP and offer a form of early triage that can be quicker for patients and also mean that GPs reduce their waiting lists. So I think actually the way we'll deal with the problems of the present is by embracing the opportunities that innovation and technology give us. And I think it's my job to support NHS organisations in that journey.
Thank you very much for taking all those questions on board. Apologies to those whose questions didn't get answered. And thank you very much for addressing Expo today. Jeremy Hunt, MP.
Thank you.